Hey guys, in this animation, I'm going to talk about percutaneous coronary intervention, which is one of the commonest procedures performed in the cath lab nowadays. This would be done for management of a patient who's having a ST elevation MI. In myocardial infarction, the first hour is called as the golden period. Why that is so is because in the first hour, there is highest chances of development of sudden cardiac death. This could be either due to tachyarrhythmias like ventricular fibrillation or ventricular tachycardia, or he could ask you regarding a bradyarrhythmia, which causes sudden cardiac death after a patient has sustained a myocardial infarction. Your answer would be Mobitz to heart block. Now, what are we going to do in such a situation if it's going to be a ventricular fibrillation or a pulseless ventricular tachycardia that you can see on the monitor? You would go ahead with defibrillation of the patient. But if it's gonna be a Mobitz to heart block, then we're gonna give atropine, and this is gonna be followed by usage of either a transcutaneous pacing or a transvenous pacing. So we have specific strategy available for management of either a tachy or a bradyarrhythmia post myocardial infarction. Well, as they say in cardiology, time is muscle. The original saying is time is money, but for us as doctors in cardiovascular system, in cardiology, time is cardiac muscle. So on the monitor at the moment, you can see a ECG of a patient of inferior wall MI. You can see ST elevation that is occurring in lead number 2, lead number 3, and lead number AVF. I have also sent the biomarkers of this patient, troponin I levels to be precise, and you know the fact that troponin I will usually take about 3 hours to rise. If a patient comes to a hospital early, like in New Delhi, there are so many cardiology hospitals. If a patient comes to the hospital early, troponin I values can be normal as well, which is why nowadays we go for serial troponin I, which means that even on admission, the value is normal. If we repeat it after 3 to 6 hours, the values are bound to rise because there is a myocardial necrosis. Now, once I made a diagnosis of inferior wall MI in the patient, my objective is to do a primary percutaneous coronary intervention within 90 minutes of the first medical contact. Therefore, either I'm going to take a transradial approach or a transfemoral approach, and nowadays transradial approach is preferred over a transfemoral. Even if we take a transfemoral approach, we are going to send up a guide wire, as you can see on the monitor, going up retrogradely from the femoral blood vessels up into the iliac artery, then into the descending aorta, the arch of aorta, ascending aorta, and then in the root of the aorta. And first, we're going to inject a dye and do a coronary angiogram. This coronary angiogram, as you can see, is going to reveal no flow in the right coronary artery because it's occluded by a large thrombus. Now we are going to deploy, or we're going to steer a guide wire further into this thrombosed right coronary artery, which is occluded. And once the guide wire is steered across this thrombus, then I'm going to deploy a balloon. The force of this balloon will destroy the thrombus, and don't worry about the debris because this debris would be sucked out. It's not going to go downstream into the perforators, causing further blockage of the smaller blood vessels in the heart. Once I have deployed the balloon, as you can see, the revascularization of the coronary artery has been obtained in a jiffy. And once we have obtained this revascularization, once the blood flow is restored downstream, you have saved cardiac muscle. Subsequent to this, you can also see that we are deploying a stent. In earlier times, we were using bare metal stents, but now we have is drug-eluting stents available. These drug-eluting stents would be covered with medications like everolimus or zotariolimus. These immunomodulator drugs are going to prevent the atherosclerosis from coming back because atherosclerosis was the root of all evil. It was a plaque fissure in an atherosclerotic plaque, which was ultimately responsible for a thrombus formation. So what you have seen in this animation is that we can not only take care of the thrombus, which is occluding the coronary artery, but we can prevent the redevelopment of a similar kind of event in the patient in future. So these are the details that I would like you to understand from this animation. And I've described the topic of myocardial infarction in the subsequent videos of acute coronary syndrome, where I've described the various differential diagnoses of ACS as well. So keep learning, guys, keep hammering and keep on learning new things every day. And the more things you learn, the more wiser you will become. Thank you so much for watching.